We're in a good position in lung cancer with increasing survival rates. The latest CRUK 5-year net survival for lung shows that about 21% long-term survival. And this is mainly for patients who've had previous surgical resection. But in fact, now patients who've had oncological treatments such as chemo-radiotherapy and some patients who are having systemic chemotherapy and immunotherapy are living for much longer. So we're seeing an increase in long-term survival. And this is something which has changed dramatically over the last 20 or 30 years. If you go back to about 1990, 5-year survival for lung cancer was about 5 or 6%. And the paradigm was you were diagnosed with lung cancer, you had some treatment which wasn't particularly effective, and you fairly rapidly died. But now it's a very different situation. We're operating on far more patients with early stage lung cancer, diagnosing more early stage lung cancers through the screening programs, for instance. We're giving more stereotactic ablative radiotherapy for patients who aren't fit enough for surgery. And as I've just mentioned, in patients receiving systemic treatments, a number of them are now living for long periods of time. And that in effect is brought into focus. What are we doing with follow-up? How are we following patients up? We follow patients up post-treatment for 3 reasons, really. The first one is to deal with any complications they have of their treatment, surgical complications, oncological complications, but they're usually dealt with in the first year or so after treatment. 5 years follow-up for lung cancer is generally, in most centres around the UK, is for about 5 years. And the majority of doctors follow patients up looking for evidence of recurrent disease. But actually, there's a new issue, and it's a good issue to have in a way. As we cure more and more patients and we have an increasing cohort of long-term survivors, we are observing an increasing number developing second primary lung cancers. This is something we haven't really seen before. In breast cancer, where they've had high survival rates for many years, they're quite used to women developing second breast cancers. But the chest physicians in the UK haven't seen so much of this in the past in lung cancer. And one bit of work we did was look back from about 2000 to 2015 and many thousands of patients who'd had treatment with curative intent. And we found that around about 1 to 1.5% of them per annum develop a second primary lung cancer. So if you've had a lung cancer resection at time 0, for the first year or 2, we don't see any second primaries, because when we initially diagnosed and staged them, we found any cancer in their body. But as time rolls on, their risk of developing second primaries increases, and it goes up over the first 5 years and then flattens out. The curve flattens out and goes fairly flat and continues on for 10 or 15 years or so. And what this means is we need to change the way we follow people up. We need to think again. Now, as I said a moment ago, most people are following patients for 5 years. A few centres are following for longer, and I would argue we need to follow people for longer. We need to look for these second primary lung cancers. For the majority of them are adenocarcinomas. And one of the really important issues is if you have a patient who has a new lesion, let's say for instance you initially have a right upper lobe lung cancer removed by surgery. 3 or 4 years later, you've got a new lesion in the left upper lobe. Now, is that a metastasis from the one in the right, or is that a new second primary? And if it's regarded as a new second primary, you'd remove it by surgery with curative intent. If, however, you said, no, this looks like a metastasis from the primary, the original primary, then the patient may go to the oncologist and get treatment for metastatic disease. And of course, their outcomes downstream will be completely different because you're no longer trying to cure people. So going forward, what I think we've got to do is get a lot sharper when we see patients with new lesions, biopsy them, get the pathology and a histopathology done and genomic analysis to say, are these two cancers related or unrelated? And if they're unrelated, treat them as second primaries, again with curative intent. We're doing some research in Cancer Research UK funded study called the SPORT study, collecting 850 patients who've had previous treatment, who are at least 2 years out from their initial treatment, who appear to be clinically cancer-free, recruiting them into the study and collecting their bloods every 6 months. And the idea of that study is to identify people developing second primaries and some with recurrences, and see if we can develop early biomarkers using techniques such as ctDNA, methylation analysis, serum proteomics, microRNA analysis, see if we can find some way of determining whether these are second primaries or recurrence at an earlier stage. With increasing survival, better outcomes for lung cancer, the landscape is changing, and the thoracic oncology community needs to adapt to that, change our practices, look in more detail at these patients, make sure we treat them optimally going forward, and potentially in the future people will be having regular follow-up for 5, 10 plus years. Combined with regular cross-sectional imaging such as CT, and possibly one day other blood biomarkers all feeding into this. Because there is at the moment a paradox. If you are 55 and you enter the Lung Health Check CT screening program, and you have a normal scan, you will have follow-up scans every 2 years going forward, and you'll end up having a dozen or so scans over the time you're in the screening program. However, if you're 55 and you have that first lung cancer proven, you're followed for 5 years, and then you're discharged. Bye-bye, have a good life kind of thing. But these people are at a really high risk of developing a second primary in the future. So at the moment there is a big difference about how we're managing different people, and we need to try and unify this. So I think it's a great, in a way it's a good problem to have, but we need to address it now and begin to find ways of looking after these people and improving their survivorship long term.